Good afternoon. Welcome to another NIPMed tutorials. And today we'll be dealing with urinary fistula. Urinary fistula. So a fistula is an abnormal communication between two epithelial surfaces. We have varieties of fistula: enterocutaneous fistula. It could be a urinary fistula, which has a lot of classification. It could be a pancreatic fistula. Could be a fistula infecting the hepatobiliary system. So different kinds of fistulas are present within the human body. But today we're focusing on just urinary fistula. Okay, so a fistula is an abnormal communication between two epithelial surfaces. All right. So in Nigeria, the major cause of urinary fistula is obstetric causes. Now you find obstetric causes being the most common cause of urinary fistula. One of the reasons epidemiologically is because of the rate of childhood and marriage, rate in which women at tender age are still getting married. So this contributes to the formation of obstetric causes of urinary fistula. Other causes could be iatrogenic following surgery, okay, and rarely could be congenital. So classification. A bladder extrophy. Bladder extrophy is a bladder that has been turned inside out and is protruding out of the anterior abdominal wall. Okay, it's a congenital cause. The acquired one are vesicovaginal fistula, ureterovaginal fistula, ureterovaginal fistula, vesicouterine fistula, and ureterovaginal fistula. So classification is just a picture. You can see the uterovesical fistula, which is the connection between the uterus and urinary bladder. You can then see a vesicovaginal fistula, connection between the vagina and urinary bladder. And you can see a ureterovaginal fistula, that is within ureter, the urethra, and the vagina. Okay, this is just anatomical classification. Alright, so for urinary fistula now, vesicovaginal fistula, ureterovaginal fistula, and vault fistula. These are the common types of urinary fistula, which is vault fistula, the ureterovaginal fistula. Okay. Now the most common cause is neglected obstructive labor. I will talk about the reason why. Obstructive labor is when the presenting part of the fetus does not descend due to mechanical reasons, usually because obstetrics we have the power, we have the passenger, and we have the passage. So in obstructed labor, the power is adequate, so the uterine contractions are strong. So we have contractions lasting for about 40 seconds, occurring every. She could have like 3 to 5 contractions in 10 minutes. So strong contractions. But the descending part, that is the passenger, is not going through the passage because the passage is too narrow for the passenger. So most likely cephalopelvic disproportion. Okay, so failure of the descent of the presenting part through the pelvis for mechanical reason. That's cephalopelvic disproportion or some form of genital tract tumors not allowing the child to go down, genital abnormalities, so on and so forth. Okay, so what happens is that the pressure that is put will be transmitted to the urinary bladder. That will not lead to ischemic sloughing. So there's pressure necrosis, pressure of the presenting part, let's say the head of the fetus now, pressing the urinary bladder epithelium constantly. Then there will be the ischemia of that area, sloughing, the areas die, and then it can be compounded by infection, and then epithelial tract then forms between the two of them. Okay, then we have the vesicovaginal fistula. Other complications could be gynecomastia, that is narrowing of the vagina, secondary amenorrhea, blood in the uterine cavity, hematometria, and could be obstructive uropathy. So this is a diagram. So you see that there is prolonged pressure of the vertex on the vagina in the obstructed labor. Then you can see the urethral passage anteriorly. Okay, so when the pressure is much there, okay, it's going to lead to pressure necrosis. Another possible cause that can lead to vesicovaginal fistula is during surgery. The bladder is damaged. Okay, so surgically the bladder is damaged and then fistula condensed. So the history will always be a history of obstructed labor or a history of predisposing surgery. We're trying to get the risk factor and then painless and continuous leakage of urine And occasionally this could have a very, very foul smelling, especially when there's bacterial superinfection. Okay, occasionally the voluntary passage of urine in the natural ureterovaginal fistula or overt fistula. So the common symptom have a history of obstructed labor or a history of surgical procedure performed, and then we have like patient complain that she's passing urine via her mouth, vagina. Okay, and sometimes they might pass some kind of menstrual blood via the via the bladder. Might urinate some form of menstrual blood or menstrual tissue, whatever that is like the mineral lining that is shed off during menstruation. Some of them might pass out in urine because of the fistula that is formed between the urinary bladder and the uterus. So, vesicle uterine fistula. So examination. When you do speculum, you want to inspect, you see that there's a urine collection in the vagina, and you might actually see the fistula. Okay, then you do a 3D swab test. Upper swab, that one is just close to the cervix. You do a middle swab, and then you do a lower swab. So upper swab is for a high fistula, middle swab is done in the mid vagina, and then lower swab just a urethra or uterovaginal fistula. You know that the urethra is below the urinary bladder, isn't it? So you do a low swab if you're trying to get a ureterovaginal fistula. Then you do an upper swab if you're trying to get a vesicle uterine fistula because the urinary bladder is actually what above, and there's a connection between the uterus and the uterine bladder. So the type of swab you do is will help you in getting the will help you in getting samples required to run the test you want to run, depending on the type of the fistula involved. Investigations involve full blood count PCV, electrolyte urine creatinine, ultrasound, intravenous urography. You do take the sample you've taken for microscopic ultrasound sensitivity, group and cross-match if necessary. And you do a pre-op EUA and dye test that's involved. You're going to put methylene blue inside the urinary bladder, and if there's a fistula from the urinary bladder, is going to enter the uterine cavity and into the vagina. So you put a cotton in the vagina, and if the vagina still stains that methylene blue, it confirms that there is a fistula. Okay, this is a picture of them doing it. So management, definitive treatment is surgery to repair the fistula. Okay, that is the important thing, and then you repair the bladder in 2 layers and then repair the vagina, and then you insert an indwelling catheter. This is to divert the urine so that a epithelial tract does not form. Another way of preventing a fistula formation in patients that have obstructed labor, if there is obstructed labor, it's also important to pass a catheter also, and the catheter should be there for at least 2 weeks to divert urine outflow and preventing a fistula from forming. Okay, so these are some post-operative management you do. Drainage of the urine, monitor the urine output and input-output charts, turn our patients from side to side, prevent stasis, analgesia, give antibiotics, and then twice weekly you check for MCs. On the 14th day, say 14th day, you remove the catheter and institute a bladder drill that's going to train the person how to bladder drill is a way of weaning off patients that have been on prolonged catheterization, a way of weaning them off urinary bladder because sometimes after being catheterized for a while, patients experience a form of incontinence. So bladder drill is you obstruct the outflow, you remove the urine bag and obstruct the outflow, but the catheter is still in situ. When that is done, the patient will tell you when they feel full. When they feel full, you then come and remove it. The patient urinates. So it's a way of training patients, weaning them off prolonged catheterization without risking them of having incontinence and reducing the risk of them developing incontinence. Okay, so no sexual intercourse for 3 months, feature delivery by elective cesarean section, no need for follow-up or conventional therapy. If unsuccessful, we try and repeat again, but usually first attempt has a relatively high success rate. So you shouldn't neglect obstructed labor, okay? Because this is a prolonged complication. You should immediate supportive care to minimize the disastrous outcome. And we need an adequate arrangement for long-term care should be made. So this usually emphasizes the importance of antenatal care. The woman has antenatal care, she actually books Those are routine antenatal visits. And what does that do? That then favors them to have a pregnancy that can be monitored, the expected date of delivery, need this, and make preparation for any possible outcome that can be done. Because certain risk factors will be noted when the patient is following antenatal that can put the patient at risk of developing an obstructed labor, such as the height. Women that are relatively short usually have some form of obstructed labor. Visual ultrasound screening might show some form of cervical mass, anything that might impede normal flow, might reveal a very relatively large baby and push the woman towards having the cesarean section. All these things will help in knowing them. Okay, so prophylaxis is always very, very important. Like I say, prevention is better than cure. Thank you.